Next speaker will be Barbara Ballard. Are you ready, Ms. Ballard?
Yes, can you hear me?
I can. Thank you very much.
I would like to thank the agency for this opportunity to speak today. My name is Barb Ballard. I am currently the director of Skid Angels for Life Foundation, where I advocate for patients with severe combined immune deficiency, usually referred to as SCID. I have no conflicts of interest. My only disclosure is that at one time I was a consultant to the Cellular Tissue and Gene Therapies Advisory Committee. I am the mother of a patient with X-linked SCID. My son passed away in 2019 at the age of 25. At the time of his passing, his bone marrow transplant was failing, and we had already collected stem cells from him to use for gene therapy. This was his only remaining option, and we knew it would be a rescue attempt. He passed away before we could begin the process necessary to receive his corrected cells. Untreated, SCID is considered fatal by the time the patient is 2 years old. Gene therapy has held the greatest promise for a full immune system recovery. Gene therapy for SCID involves transferring a normal gene into a patient's hematopoietic stem cells, which have been removed from the bloodstream using apheresis. The cells are then reintroduced back by an IV into the body after niches have been created in the bone marrow, typically with chemotherapy. This approach aims to offer the advantages of allogenic transplantation without the risks of graft rejection. The history of XSCID gene therapy in particular has had its ups and downs. While studies performed more than 20 years ago showed the feasibility of the therapy, successfully correcting the T-cell defects, there was an occurrence of vector-related leukemia in a handful of patients. Since then, new vectors and isolators have been tested and incorporated into the latest trials to enhance the outcome and reduce the potential for side effects. ADA SCID and Artemis SCID have seen extremely successful clinical trials for gene therapy without the occurrence of vector-related leukemia. This history of adverse events is the exact reason that long-term studies and registries are necessary post-gene therapy. Long-term studies should not only include incidences of adverse events, but also the quality of life for patients post-therapy. This is critical information needed to evaluate the true efficacy of gene therapy. While patients and their families want to know immediately about any adverse events caused by therapy, what they really care about is how the patient's life is after the treatment. Patients and families who understand that the information regarding their own experience with a therapy can help other families gain an understanding of the process are more likely to consent to participate. Additionally, knowing whether or not relevant patient advocacy groups recommend participation in a study helps patients and families decide whether or not to participate. If long-term follow-up requires additional follow-up appointments with the medical team than would otherwise be required, the patient and their caregivers need to be made aware in advance of the cost they will be expected to bear in terms of time and travel. The patient's privacy and anonymity should, of course, be protected. Physicians and researchers need to explain in detail to the families involved exactly how that privacy is ensured in plain language. Plain language summaries should include all the information on how the registry will be used, operated, and managed, as the average person without a medical background rarely has the experience to know what to question on their own. When families feel they are presented with consent forms that they cannot fully understand, they quickly feel threatened and become defensive. Plain language summaries of all consents should be a requirement across all institutions. Thank you for your time today.
Thank you.